Welcome to the deep dive. Today we're tackling Hirschsprung's disease. It's a condition you might hear about, especially regarding childhood constipation.
Yeah, it's a really important one to understand. It's congenital, affecting the large intestine.
And we've got some solid revision notes here, so our mission is to really break this down, get the key info you need.
Exactly. We'll cover the definition, causes, symptoms, the whole picture diagnosis, management, complications, making it clear and hopefully memorable for revision.
Great. Let's dive right in. Definition first. What exactly is Hirschsprung's disease?
Okay, so simply put, it's a birth defect where you're missing specific nerve cells, ganglion cells, in the very last part of the large intestine.
Missing nerve cells.
Yeah, and because those cells aren't there, that section of the bowel can't work properly. It leads to a functional blockage.
Functional, so like there's no actual physical lump blocking thing.
Precisely. The plumbing itself is physically open,
Ugh.
but it doesn't function right because the control system, those nerves, are absent in that segment.
Got it. And this lack of nerves, where does it come from?
It boils down to a problem during development in the womb. There's a failure in forming these nerve networks, specifically the parasympathetic Auerbach and Meissner plexuses.
The sort of internal wiring for the gut muscles.
That's a good way to put it. Those plexuses are essential for coordinated muscle contractions, for peristalsis. Without them, that bit of bowel just can't relax or push things along.
Okay. How common is this? Are we talking really rare?
The figure is around 1 in 5,000 live births. So maybe not everyday common, but definitely significant enough that you need to know about it, especially when thinking about childhood constipation causes.
1 in 5,000. And anatomically, where is the problem usually located?
It almost always involves the rectum, the very end section, but it can extend upwards into the colon for varying lengths, sometimes short, sometimes much longer. Very, very rarely does it involve the small intestine.
And you mentioned these nerve cells, the ganglion cells. Where do they normally originate?
It's quite a journey. They start as cells called neural crest cells very early on in embryonic development.
Neural crest cells, right.
And these cells are meant to migrate all the way down the developing gut. In Hirschsprung's, something interrupts that migration. They don't make it all the way to the end.
So they stop short.
Exactly.
Mm-hmm.
The segment they don't reach is called the aganglionic segment. A meaning without. Ganglionic, referring to the ganglion cells.
Makes sense. And that's what causes the functional obstruction we talked about.
Yep. No nerves, no proper relaxation or movement equals blockage.
Okay, so that migration failure is key. Let's talk etiology, the why. What causes this migration to fail?
Well, the primary cause is that failure of the neural crest cells to migrate properly during those crucial early weeks. But it's often not just one single factor.
Okay. Complex.
Yeah, genetics definitely play a part. Researchers have linked several genes and chromosomes like X, 10, 13, others too. You don't need to memorize the numbers, but it shows there's a clear genetic link that's being studied.
An environment.
Environmental factors are thought to play a role too, potentially certain exposures during pregnancy, but the specifics are still under investigation. It's likely a mix of genetic predisposition and maybe some environmental triggers in many cases.
Right. And the notes mention associations with other diseases. That seems pretty important.
Absolutely crucial. Hirschsprung's isn't always isolated. You see it more often in kids with Down syndrome, about 15% of them.
15%? Wow.
Yeah. And also associations with rarer conditions like MEN2A and MEN2B. Those are multiple endocrine neoplasia syndromes. Also Waardenburg syndrome, congenital deafness, malrotation of the gut, intestinal atresia. Quite a list.
So spotting one of those might make you think about Hirschsprung's too.
Exactly. It raises your index of suspicion. Oh, and also, it's sometimes linked with meconium plug syndrome in newborns where the first stool forms a blockage. Estimates vary, but maybe 3% to nearly 40% in some studies.
Okay, so lots of potential connections. What about specific risk factors that increase the chance of a child having it?
Well, family history is a big one. If it's run in the family, the risk is higher.
Makes sense with the genetic links.
Definitely. And as we said, having certain genetic syndromes, particularly Down syndrome, is a major risk factor. There's also some suggestion, some studies point towards maternal smoking during pregnancy, potentially increasing the risk slightly.
Okay, so family history, genetic syndromes, maybe smoking. Let's dig into the pathophysiology a bit more. How does that missing nerve section cause the actual problems?
Right. So the core issue is no ganglion cells in that distal segment means no relaxation. Peristalsis, the coordinated wave-like contractions that push stool along, just doesn't happen properly in that affected area.
So it's like a stiff, unresponsive pipe?
Pretty much. It can't relax to let stool pass, and it can't contract to push it. So stool backs up in the healthy bowel just before that segment.
And that causes it to swell up.
Exactly. The bowel proximal to the ganglionic segment gets dilated, stretched out because of the buildup. And again, it all stems from those neural crest cells, or rather, the parasympathetic neuroblasts not completing their journey.
Got it. Creates a bottleneck. Now, differential diagnosis. If a baby or child presents with symptoms suggesting a blockage, what else could it be?
Good questions.
Yeah.
Especially in newborns, you have to think about other causes of intestinal obstruction. Things like intestinal atresia, a physical blockage or narrowing,
Okay.
or meconium ileus, often linked with cystic fibrosis, where the meconium is super thick and sticky. And meconium plug syndrome, which we mentioned, can be associated with Hirschsprungs, but can also occur on its own.
Right. And you mentioned it's more common in boys.
Yes, the male-to-female ratio is often quoted around 3.1 or even 4.1. And remembering the association with Down syndrome is also helpful when you're weighing the possibilities.
Okay. What about the numbers here in the UK? Epidemiology.
Yeah, the incidence is pretty consistent, around that 1 in 5,000 live births mark here, too.
And the male predominance holds.
Yes, about 4 males for every 1 female affected. Some data also suggests it might be slightly more common in babies of Asian or African descent.
Interesting. And diagnosis age. You said it's congenital, but when do they usually find it?
Most cases, probably over half, are diagnosed within the first year, the majority by age 2. But sometimes, if it's a very short segment affected, the symptoms might be milder, more like chronic constipation, and it might not get picked up until later childhood, or even, rarely, adulthood.
That delay really shows how varied it can be. Okay, let's talk clinical features. How does it actually look? What signs do you see?
It really depends on the age. In a newborn, the absolute classic sign, the red flag, is failure to pass meconium within the first 48 hours.
That first poo, right?
Yeah. Alongside that, you often see a swollen, distended abdomen and repeated vomiting, which might be green or yellowish because it contains bile.
Okay, key signs for newborns. What if it's missed then, or it's a milder case presenting later? What about older infants and children?
In older kids, it typically presents as really stubborn chronic constipation, the kind that doesn't respond well to the usual laxatives or dietary changes.
So really difficult constipation.
Yes, they might even need daily enemas just to clear their bowels. Sometimes, weirdly, you can get overflow incontinence or soiling, where liquid stool leaks around a hard mass of impacted stool.
That must be distressing.
Very. And you might also see early satiety feeling quickly abdominal discomfort, that persistent distension, all of which can lead to poor appetite, poor nutrition, and faltering growth.
And I see the notes mention enterocolitis. That sounded serious earlier.
It is very serious. Hirschsprung-associated enterocolitis, or HAEC. It's an inflammation of the bowel that can occur at any age in someone with Hirschsprung's, even after surgery sometimes.
What are the signs of that?
Think sudden onset abdominal pain, fever, really foul-smelling diarrhea, sometimes bloody and vomiting. It's a medical emergency because it can rapidly progress to sepsis, bowel necrosis, even perforation if it's not treated fast.
Wow, okay. Definitely something to be vigilant about. What about physical examination findings? What might a doctor notice?
In a neonate, you'd likely see that abdominal distension, often quite marked. It might sound tympanic, like a drum, when you tap it. Clear signs of bowel obstruction. Rarely they might present acutely with enterocolitis or symptoms mimicking appendicitis.
And in older kids?
Again, often chronic constipation signs. Marked abdominal distension is common, and you might actually be able to feel loops of dilated colon through the abdominal wall.
Really?
Yeah, and a key finding on rectal exam can be an empty rectum because the blockage is higher up. But then, as you withdraw your finger, there might be a sudden, forceful expulsion of gas and liquid stool. That's quite suggestive.
The squirt sign.
Sometimes called that, yes.
Yeah.
And in more long-standing cases, you might see signs of malnourishment, and again, they could present with enterocolitis.
Okay. I see we have some mnemonics here. Always helpful for revision.
Yeah, let's run through them for newborns. Think no meconium, big belly, bad burps.
No meconium, failure to pass, big belly, distension, bad burps, vomiting. Got it.
And for older children,
Yeah.
can't go regularly, enemas needed, belly big, growth bad.
Can't go regularly, constipation, enemas needed, belly big, distension, growth bad, poor nutrition growth. Nice and simple.
Hopefully helpful.
Definitely. So, suspicion is high based on these signs. How do we confirm the diagnosis? What investigations are key?
Well, clinical suspicion is important, but you need tests. A contrast enema is often one of the first steps.
Where they put dye in the back passage?
Exactly.
Yeah.
A special contrast liquid is introduced via the rectum, and then x-rays are taken. It helps visualize the shape and caliber of the colon.
What does it show in Hirschsprungs?
Typically, in older infants or children, you might see a narrow distal segment, the ganglionic part, then a sort of funnel shape, the transition zone, leading into a dilated, widened proximal colon, the healthy part that's backed up. Though it's important to know, in very young babies, or if the entire colon is affected, total colonic agangliosis, the contrast enema might actually look normal initially. So it's not foolproof on its own.
Right. What else? Abdominal x-ray?
A plain abdominal x-ray can be useful, especially if you suspect obstruction. It might show dilated loops of bowel, maybe a lack of gas in the rectum.
And you mentioned anorectal manometry.
Yes, that's a test that measures the pressures inside the rectum and anal canal. It looks for a specific reflex, the rectoanal inhibitory reflex, which is usually absent in Hirschsprungs. It can be helpful, especially in older children with atypical symptoms, but it's not the definitive test.
So what is the definitive test? The gold standard?
The gold standard is the rectal biopsy. You need to take a small sample of tissue from the rectal wall and look at it under the microscope.
To look for the ganglion cells. Or the lack of them.
Exactly. To confirm the absence of ganglion cells in that distal segment, that's the proof. This can be done via a suction rectal biopsy, which is less invasive, or sometimes a small surgical full-thickness biopsy is needed.
Got it. Biopsy confirms it. Any role for genetic testing?
Sometimes, yeah. Particularly if the child has other features suggestive of a syndrome known to be associated with Hirschsprungs, like Downs or MEN2. And there's research looking into potential blood tests, identifying serum proteins maybe for earlier screening, but that's still more in the research phase.
Interesting potential for the future. Okay, diagnosis confirmed. What's the management strategy?
Management is primarily surgical. The goal is to remove the aganglionic segment of the bowel.
Cut out the bad bit.
Essentially, yes.
Yeah.
But before definitive surgery, you often need initial measures. Rectal washouts or bowel irrigation can help decompress the bowel and clear out stool, relieving the immediate obstruction.
Like clearing the traffic jam temporarily.
Exactly. Then the main surgery involves removing that non-functioning segment and connecting the healthy ganglion-containing bowel down to the anus or the remaining rectum.
Are there different ways of doing that surgery?
Yes. Several techniques have been developed. Historically, procedures like the Swenson procedure involved an abdominal operation. More commonly now, surgeons use pull-through procedures, often done transanally through the anus, avoiding a large abdominal incision.
Ah, less invasive.
Often, yes. Techniques like the Suave or Duhamel procedures or transanal endorectal pull-through, TURPT, they often use frozen sections during the operation, quick biopsies sent to the lab to make sure the bowel they're pulling down actually has ganglion cells before they make the final connection, the anastomosis.
That makes sense. Ensuring you're connecting healthy bowel.
Precisely. And techniques are always evolving to try and improve long-term function and minimize complications.
What about temporary measures? Sometimes they need a stoma.
Yes, sometimes. Particularly if the baby is very unwell, has severe distension, or has enteral colitis, a temporary stoma like a colostomy or ileostomy might be created first. This diverts the stool away from the diseased segment, allows the bowel to decompress and heal, and lets the child grow stronger before the definitive pull-through surgery is done later.
Okay. And how do you manage that dangerous enterocolitis if it happens?
That requires immediate aggressive treatment. Broad-spectrum intravenous antibiotics are crucial. Aggressive 5-E fluid resuscitation is needed because they can get dehydrated very quickly. And thorough bowel decompression and cleaning with rectal irrigations or washouts are essential. It's a critical situation.
Definitely sounds like it. What about managing acute obstruction before surgery?
Similar principles. Stop feeds, make them NPO, nothing by mouth. 4-V fluids for hydration. An NG tube, nasogastric tube, might be passed to help decompress the stomach and upper bowel. And gentle saline enemas or washouts can help clear the lower blockage.
Okay. And after the big surgery, the pull-through, what's the care like then?
Post-operatively, it's about recovery and establishing good bowel function. Regular follow-up is really important. Some kids might need a bowel management program, maybe involving laxatives or enemas for a while, to help things regulate.
Do they need a special diet long-term?
Usually no special diet is needed once they've recovered and bowel function is established. But obviously, a healthy, balanced diet is always good. If problems like constipation persist, then dietary adjustments might be part of the plan.
And you mentioned referral to genetics if it's part of a syndrome.
Yes, if Hirschsprung's is diagnosed alongside features of something like Down syndrome or MEN2A, then referral to clinical genetics is important for overall management and counseling.
Right. And looking ahead, any future therapies on the horizon?
There's some really exciting research happening. People are exploring the potential of using stem cells, specifically neural crest-derived stem cells, to try and repopulate the ganglionic segment with nerves. Also, tissue engineering approaches. The hope is maybe one day to restore function without needing major resection, potentially reducing risks like long-term incontinence. Still experimental, but promising.
That's really fascinating. Okay, so what's the overall outlook? The prognosis?
Generally, with timely diagnosis and appropriate surgery, the prognosis is actually very good. Most children go on to achieve fecal continence and have much improved bowel habits. Quality of life is usually significantly better.
That's great news.
It is. However, it's not always perfect. A significant minority, maybe 30 to 50%, might experience some persistent bowel symptoms even after surgery, things like constipation, occasional soiling, or recurrent enterocolitis risk.
So ongoing management might still be needed for some.
Yes, exactly. And it's worth noting that the prognosis might be a bit less favorable for children who also have Down syndrome. They seem to have a higher rate of persistent issues and might be more likely to need a permanent colostomy, unfortunately.
Okay. And what are the main complications to watch out for, even after successful surgery?
Yeah, complications can occur, which is why follow-up is key. Soiling or incontinence can happen, though significant incontinence is thankfully rare, maybe less than 1%. Persistent constipation affects a larger group, perhaps around 10%. There's a small risk of an anastomotic leak, a leak where the bowel was joined together. Enterocolitis can still occur post-operatively, maybe in around 12% or so, according to some reports, so parents need to know the warning signs. Later on, you can sometimes get a stricture, a narrowing at the anastomosis site, or potentially late bowel obstruction caused by adhesions from the surgery.
So generally good outcomes, but definitely things to monitor. Let's wrap up. Key takeaways for Hirschsprung's disease.
Okay, key points. It's congenital, caused by failed neural crest cell migration, leading to a ganglionic segment in the distal bowel. This causes functional obstruction. Presentation varies: failure to pass meconium in newborns, chronic constipation in older kids. Watch out for enterocolitis. Diagnosis is confirmed by rectal biopsy. Management is surgical removal of the affected segment, usually a pull-through procedure. Prognosis is generally good, but long-term follow-up is crucial for managing potential complications like constipation or enterocolitis.
Excellent summary. It really drives home how crucial that early recognition is, especially those newborn signs, for getting timely intervention and improving those long-term outcomes.
Absolutely. Early diagnosis makes a huge difference.
So a final thought for our listeners. Considering that impact of early diagnosis, what do you think are the most critical elements in making sure Hirschsprung's disease gets picked up promptly? Something to ponder maybe about awareness, screening, or specific clinical signs?
That's a great question to reflect on. And of course, if you want to cement this knowledge and revise other key topics for your exams, do check out passthemsra.com.
And for free resources and questions, head over to freemsra.com.
Great resources for revision.
Thanks so much for that depth dive today. Really cleared up Hirschsprung's. Hope you found that useful, and join us next time.